So we also did personal exposure monitoring in the graphs, and this is the exposure monitoring strategy. So in the graphs, CO, carbon monoxide, was the primary pollutant, and then we also secondarily monitored PM2.5 in a subset of the cohort. So we did a baseline monitoring prior to deployment of the intervention, the cook stove interventions, and then following that, there were 3 more exposure rounds prior to delivery, and after delivery, 3 more exposure assessment rounds. So each exposure assessment session lasted for 72 hours. So we had these 72-hour periods, multiple time points across pregnancy and then across the first year of life of the child. So now I'll show you some results from the graphs. So first of all, we determined the effect of the cook stove intervention on personal exposures, so CO and PM2.5. So for CO, we were able to carry out a proper analysis. So we did a differences regression to determine the effect of the LPG and the BioLite improved cook stove on CO exposure. But for PM2.5, we only had the post-intervention PM2.5 exposures, so we could only compare across arms. So in our primary specification differences approach, the LPG arm showed a 47% reduction in mean 48-hour CO exposure compared to the control arm. So that's a moderate reduction, right? In a community setting, there are other sources of air pollution apart from what occurs in the household. So for the health impacts, but I must say that when we analyzed the effect of the intervention on the health outcomes of birth weight and pneumonia, so we did not find any evidence of improvement in birth weight and pneumonia incidence for the study interventions, right? But then we went ahead and did exposure response analysis where we related the exposure, so CO, PM2.5 to health outcomes. And here we show the exposure response association between prenatal CO and pneumonia incidence. So we found that for every 1 ppm increase in prenatal CO, the risk for pneumonia increased by 10%, and the risk for severe pneumonia increased by 14%. So that's represented by this exposure response curve here. And then we also did a sex-specific analysis by introducing interaction terms between child sex and the exposures. And we found that, so this increased risk was almost entirely seen in girls compared to boys. So for the birth weight outcome, we also found that in the overall cohort, so increasing prenatal CO was inversely related to birth weight, right? But then we did a stratified analysis by placental malaria status because our study area is a malaria endemic area, and placental malaria or prenatal malaria or malaria in pregnancy itself is a big risk factor for low birth weight, right? So we stratified the results by placental malaria status, and we found that in children born to women who did not have any evidence of placental malaria, a 1 ppm increase in prenatal CO was associated with a mean reduction of birth weight of about 53 grams. Okay. So we also assessed other health endpoints. So apart from the primary outcomes of birth weight and pneumonia. We also measured lung function in the infant. So at approximately 1 month of age, we measured lung function using a passive method, and we found an inverse relationship between increasing prenatal CO and expiratory function. So this meant that increasing prenatal CO was associated with impaired expiratory function. And then, so a direct association between respiratory rate and increasing prenatal CO. So that's a bad thing, right? So we also went ahead and we examined time-varying associations between prenatal HAP exposures and birth weight and pneumonia. So the previous results that I showed for birth weight and pneumonia averaged the exposures over pregnancy, right? But here we used reverse DLM models to identify sensitive windows of exposure. So because this gives us the time-varying association, we're able to identify which periods in pregnancy that an increase in air pollution exposure is associated with low birth weight or increased risk of pneumonia. So for birth weight, we found that higher CO exposures in mid-gestation, so between 15 and 20 weeks, was associated with higher odds of low birth weight. And then we also went ahead and did our stratification by sex. And for girls and boys, we found that the window for girls was earlier at 10 weeks, and the window for boys was also mid-gestation, 16 to 20 weeks. And for the severe outcome, the sensitive window, so this is the period in which exposure was associated with higher odds of severe pneumonia. So this window was in late gestation between 34 and 39 weeks. And in the sex-stratified analysis, we only found the effects in girls, just as we saw in the previous analysis where we averaged the exposures. So following on from the graphs intervention ended when the children turned 1 year of age. Following on from that, we are prospectively following up so children and moms who belonged to the LPG arm and the control arm, and also a smaller number of children and moms who were in the improved BioLite arm. So we are following them up prospectively. We are assessing lung function. We are measuring blood pressure, and then we are also we are continuing with our air pollution monitoring, so personal PM 2.5 exposure monitoring, as well as, so now we are introducing ambient monitoring as well in the study area. So our hope is that we'll be able to continue following up this cohort well into adulthood. Now we have funding to follow them up until the children are 13 years. The average age of the cohort is around 9 years as we speak. So, so this is the field where we are assessing lung function in the kids. And we use the master screen iOS, so impulse oscillometry, to measure lung function. So we have iOS parameters, so, and then we have spirometry parameters. So I'll give some of the results that we've found from these measurements. So here we looked at the relationship or the association between prenatal CO exposure and lung function at age 4. So in the previous slide, so we did lung function measurement at age 4, at age 7, 8, and then the next round will be at 13 years, right? So at age 4, so we used the same DLM model to determine time-varying association between prenatal exposure and lung function at age 4. And again, we found a sensitive window in late gestation from 35 to 40 weeks, in which increased CO exposure was associated with impaired lung function. Now, when we looked at the ITT analysis, or intention to treat analysis by Cook-Stove arm, so that result is shown on the right here. So we found that the LPG intervention was associated with more positive lung reactance and then more negative lung resistance. So reactance is lung compliance. So you want your compliance to be higher. So the lungs should be able to comply and fill with air. Resistance, we don't want resistance to be high because that means airflow limitation, right? That's poor lung function. So we found that in the LPG arm, children belonging to the LPG arm at age 4 had better lung function compared to those in the control arm. And for the BioLite arm, the improved biomass arm, so this, in the opposite direction, children in this arm had higher airway resistance and worse small airway compliance compared to the control arm. So we are also collecting data on cardiovascular risk, so mainly blood pressure. So we do annual blood pressure measurement, resting blood pressure measurement, and we have plans to also do ambulatory blood pressure measurement, as well as measure heart rate variability. And then we're also doing some biomarkers of cardiovascular risk. But so far we've collected some data on resting blood pressure. And again, using our DLMs, we found that higher CO exposure between 35 and 40 weeks gestation was associated with higher diastolic blood pressure at age 4. And when we did this analysis by study arm, so we found in that this is the multivariable model which adjusted for confounders or covariates. So in this analysis, we found that children in the LPG arm had lower diastolic blood pressure Z-scores compared to those in the control arm.